100 people who we have over 1,200 people who have registered for this important webinar, and we're very pleased that we have Debbie Kale here, who's going to give us a great talk on pulmonary rehabilitation, billing, and coding. Debbie has a master's degree. She's the manager of the Pulmonary Rehab and Pulmonary Function Testing Labs at IU Health Methodist in Indianapolis. And Debbie's a long-term volunteer for the AERC. She worked very hard with colleagues from other professional societies to put together a toolkit to make sure that appropriate coding is done to ensure that an adequate reimbursement rate continues to be available for pulmonary rehabilitation. I want to thank you, Debbie, for your advocacy for respiratory care and your advocacy on behalf of patients. And before we launch into your talk, I'd just like to mention that the webinar series for government affairs next month will feature the chair of the Compact Licensure Task Force doing a short coffee talk with a guest. And so you can expect to hear from us next month with that. With that, let me turn it over to you, Debbie. It really is my pleasure to have you here. And thank you so much for doing this on behalf of AERC's membership.
Oh, thank you, Miriam. It is my pleasure to do this. This has been a project I've been pretty passionate about since 2010, when our first toolkit came out for billing and coding for pulmonary rehab. I hope all of our participants enjoy this and then gain some knowledge. One of the things that we know is that pulmonary rehab is extremely important to our patients. Like Miriam said, I've worked with other societies to get this message out there. And we want to make sure that billing and coding is correct so that what we do is important and what we get paid for should be equally important. So enjoy this webinar, and please put questions in the Q&A part, and we'll be more than happy to answer those at the end of this webinar. And it should be a lot, well, I wouldn't say a lot of fun, but you should get a lot of knowledge out of this, and enjoy. Good day, everybody. Today we are going to talk about improving reimbursement for pulmonary rehab. I'm Debbie Kale. I have a master's degree. I'm a respiratory therapist for more years than I care to admit at this time. And I manage the pulmonary rehab and the PFT labs at IU Health Methodist in Indianapolis. And I'm very happy to be talking to you guys. This is kind of a passion language, I should say, lecture for me. Because we have been talking about this for the last 10 years since we got the pulmonary rehab code approved way back in 2010. So I hope you will gain a lot of information from this lecture, and I hope it's very practical for you, because I think it's something that as respiratory therapists and people who work in pulmonary rehab, we need to think about a lot and consider to make sure that we're providing the best services for our patient at the correct cost. So what do we know about pulmonary rehab in general? We know that, we're looking at it in kind of parts. We know what pulmonary rehab is. It's a terrific service we give to our patients to help anybody with lung disease lead a healthier life, a more productive life, get them into better shape around those diseased lungs that they have. And we know that it works. There's tons and tons of scientific literature out there that says pulmonary rehab works. It's one of the few things in the COPD Gold Guidelines that says this is meant to be, and you need to give it to your patients because it's one of the non-pharmacological treatments that we can provide, and it works. As of 1/1/2022, we do have 2 new codes for COPD and for COVID patients. Years ago, in 2010, when the new code came out, it was the GO424 code. This year, they switched it to 2 codes, a 94625 and a 94626, which we will talk about those codes a little bit later. But do realize that it's for COPD, and they added COVID really quick at the beginning of this year, which is a perk for all of our COVID patients. We do know that for these 2 codes, we have to have pulmonary function tests to qualify our COPD patients, but we do not have to have pulmonary function tests for our COVID patients. And we will talk about, like I said, we'll talk about that a little bit more later. Now, the next thing we know about pulmonary rehab is that we have these respiratory services codes. These were kind of our original PR codes before we got the official one. And those are the GO 237, 238, and 239 codes, which are for all of our other patients, which can include COPD, believe it or not. These are codes in which we need medical necessity for these diagnoses. So although it's not technically pulmonary rehab, they are respiratory services codes, but they are used all the time in pulmonary rehab programs for those patients that don't qualify for the 94625 and the 94626. And again, we'll discuss that and kind of break that down in a little bit. When we look at payers for pulmonary rehab, we know we've got probably three big ones. We have Medicaid, we have Medicaid plans, we have Medicare and Medicare plans, and replacement plans, and we have private insurance. So we have a lot of stuff to consider, and all of those work a little bit differently, and we need to remember that. For traditional Medicaid, I live in the state of Indiana, and traditional Medicaid does not pay for pulmonary rehab services. So that's kind of weird, and it's never been much fun to deal with. But we have a lot of Medicaid plans that do pay for pulmonary rehab. So a lot of our patients that have Medicaid plans, which are kind of similar to Medicare plans, pulmonary rehab is a covered service. So that's kind of nice to know. Medicare is great. We know that. Traditional Medicare, we know that it does pay for. Replacement plans, on the other hand, sometimes have higher copays. Now, we've seen those copays capped recently. They used to be as high as $30 or $40, which was crazy considering that if someone just had straight up Medicare, they were paying a whole lot less for a copay than the copay plan that the replacement plans were charging patients. So pay attention to that when you're looking at your patients to see what those copays actually are. Private insurance will often follow Medicare rules, but sometimes they don't, and you may get away with more visits. You may get away with less copays, but each private insurance is different, and so you need to look at that for your patient to figure that out. And then we had a virtual option that was happening. Now, the caveat to that virtual option is that it's only good now until May of 2023, and a lot of our professional societies, AARC, AACVPR, American College of Chest Physicians, ATS, are trying to convince the government and CMS to continue with those virtual options for these programs, because we found out that they did work, and we don't want them to stop. But right now, because we're ending our pandemic pay, so to speak, and that we only have this virtual option until May of 2023. So there's a lot of, with that public health emergency, there's a lot of things that are coming and going in May, and some things are ending in December, and you kind of need to keep an eye out for that information, which our professional societies will kind of let us know what's going on with those. So there's a lot of stuff that we need to know about PR, and that as a pulmonary rehab professional, keep our eye on, because it's important to us. We want to serve our patients, but we also want to make sure that we're getting paid for that service that we are providing. So, pulmonary rehab. This is a statement from 2013 from ATS and the European Respiratory Society. And they're going to issue some new information this year. But if you read about this, if you read this statement and you do pulmonary rehab, you're going to say, oh yeah, that makes perfect sense. And I often outline this to folks, that this is what rehab is. It's comprehensive. We do a patient assessment. We tailor therapies to that patient. That's not limited to exercise, education, behavior changes. It's designed to improve their physical and psychological conditioning. And it's for anybody with chronic respiratory disease, and that we want to promote that long-term adherence and health-enhancing behaviors. Now, think of that statement when we're going to start talking about billing, because when we want to it's going to take a lot. We have to think about, we're doing a lot of things for this patient, but if we look at it, we're not getting paid a whole lot to do that, and there's reasons behind that. We know that the rationalization for PR and their greatest benefits we know is symptom relief, getting rid of that shortness of breath, improving that exercise tolerance, getting those people off the couch and getting them moving again, improving their health-related quality of life, letting them go out and do things with their families, their grandkids, their friends, and that emerging data actually says that it reduces healthcare utilization and expenditures. That's been one of the hardest things to actually look at, because we all like to research the relief and the exercise tolerance and the quality of life, but looking at healthcare utilization expenditures is a little bit more difficult oftentimes to quantify. But we've got some data out there saying, hey, it's happening, and we know that this is a good thing for our patients. Couple big evidence-based guidelines that I always refer people to when we're talking about pulmonary rehab. The joint ACCP and AACVPR evidence-based clinical practice guidelines are out there. Australia and New Zealand have some great practice guidelines as well to look at, and they're really, really pretty similar. The ATS is getting ready to release some new evidence-based guidelines, which we're all kind of hoping and can't wait till they come out to see what has changed with any of it. I'm excited to see it. The guidelines from Australia and New Zealand were published in 2017. They're very, very similar, except that they recommend PR for more mild diseases and symptoms, and they have a place for PR at home in their guidelines, which is kind of nice, and they have PR for other lung diseases as well. So there's a lot. They've added a little bit more, they've tweaked it a little bit more than what we've had currently, but it's all very research-based, and they're all very good guidelines. So I'm really excited to see what's going to come out with our newer guidelines, and hopefully it'll mimic some of this stuff from Australia and New Zealand as well. There's also, if you're doing pulmonary rehab, this is another tool that if you don't have it, I would highly recommend that you get this book. It is the Guidelines for Pulmonary Rehab Programs. It's the 5th edition. It's the most current edition that's out there. It's a resource for all kinds of good things. It's a resource for program certification through the AACVPR. It's a resource if you're starting a new program and you need information. This is a great book to have on your bookshelf to look at. It can help you, and it can help you keep your program structured. It was the resource for an outcomes toolkit. It was also the resource for our AACVPR AARC toolkit on billing that we're going to talk about a lot today. So it's got a great amount of information in it that if you don't have this book, I would highly recommend getting it, because it's going to help you design your program and know what you need to do and how you need to do it. So let's talk about those codes I said we would go into more detail about. 94625 and 94626 are our two codes for COPD and now COVID. And those are the codes you need to use when you're taking care of patients with COPD stages 2, 3, and 4, and any patient who has COVID. And we'll talk about how we figure that out and what we're going to use for defining it. Now, here we've had a lot of discussion on the 94625 and the 94626. Those two CPT codes. What they did in CMS is they sort of mimicked what we do in cardiac, or what's done in cardiac rehab. Cardiac rehab has two codes, that is with and without monitoring. They decided that they were going to do the COPD codes, the 94625 and the 94626, with and without continuous oximetry monitoring. And the key word to this is continuous oximetry monitoring. Are you monitoring that patient continuously, meaning that they're exercising with that oximeter on their finger, on their ear, on their forehead, whatever type of monitoring you use, and is it being monitored continuously? Or is it without continuous, meaning that you're doing it intermittently? For whatever reason, CMS thought we were going to use the continuous oximetry all the time, and both AARC and AACVPR said, yeah, no, not really. We don't use them continuously. We often spot check, but there are some patients that you do use them continuously with. Now, the caveat here is that there's no difference between the reimbursement on either of these codes. But what you need to do is make sure you're charging appropriately for how you are monitoring your patients, and that's a key thing. Do remember, a session of pulmonary rehab is defined as 60 minutes, and it must be at least 31 minutes to be a session. If 2 sessions are delivered, the first session is equal to 60 minutes, and the second session must be at least 31 minutes, which means it has to be 91 minutes or more is considered a session. So don't forget that when you're looking at your charges, to make sure that you're doing that correctly. And then I already talked a little bit about that continuous pulse oximetry. We had a lot of discussion. Is it necessary for the patient? Is it for staff convenience? Is it truly value-based care? Whether you're doing continuous or non-continuous, what is correct for your patient? And make sure that you actually document everything appropriately, because that is going to make a big difference. If you ever get audited, they're going to ask you, well, it doesn't show on your paperwork that you're monitoring this patient continuously, but you charge for continuous oximetry monitoring. Why did you do that? So just make sure that you can define and you can defend why you're using either one of these charges. 94625 and 94626 is truly the official code for pulmonary rehab. If you look this up, this is what defines pulmonary rehab. If we're using it for COPD, remember it covers the COPD diagnosis. Truly the J44.9, obstructive chronic bronchitis without exacerbation, but anything that falls into that COPD diagnosis, simple, with or without exacerbation, acute emphysema, alpha-1 antitrypsin disease, that is your COPD diagnosis. It's the best and probably easiest if we can use the J44.9 because it defines it the best, but all these other codes should work as well. You must have pulmonary function test to verify your diagnosis. Ideally, it should be post-bronchodilated, but we don't always have that because realistically, we don't always get them. And they must have gold stage 2 or greater, which is your FEV1 less than 80%, and your FEV1 FVC is less than or equal to 70%. And those are 2 key numbers you need to remember. We went through a CMS audit, and they wanted to know how we knew that this was a gold stage 2 patient, and we had to pull out those PFTs and say, this is how we know it's gold stage 2, 3, or 4. I just couldn't say, hey, we never take anybody that's stage 1. That didn't work. So you've got to be able to prove that for COPD, you're using gold stages 2, 3, and 4 if you were using the 94625 and the 94626 codes. Now for COVID, it's a little different. You do not have to have a pulmonary function test. In fact, you don't even have to have a positive COVID-19 test. And you don't have to be in the hospital. But what the patient has to have is a clinical note that says they have persistent symptoms that include respiratory dysfunction for at least 4 weeks after COVID-19. And you have to have 2 codes on your billing for COVID to be covered under the 94625 and the 94626. And this started on January 1 of 2022. So it's there. Actually, I should say 2020. Yeah, 2022. The first diagnosis you need to have is one of these 7 that are listed here: pneumonia due to COVID-19, MIS, the multi-inflammation system, chronic respiratory failure, acute respiratory distress syndrome. You can actually have viral cardiomyopathy, and really commonly we see shortness of breath. That's probably the most common one we see besides pneumonia. And then the second code you have to use is U09.9, which is post-COVID-19 condition. And I will tell you, it's pretty easy to find this. If you get a patient that is referred to you for COVID and having 4 weeks of dysfunction, you can find these codes probably in any history and physical, but you need to make sure that you're coding your diagnoses accordingly with both of these codes so that you can get paid to do this. Now, how do we use these 94625 and these 94626 codes? One thing to remember about these two codes, and when CMS created it, they came out and said, hey, this is a bundled code. Okay? What bundled code means is you need to consider all of the services you provide to your patient during a pulmonary rehab session. That's your oxygen, your education, your 6-minute walk, your oxygen assessment, okay? Everything that you do for that patient, you need to consider, and that's your bundled code, and that's how much you should charge for your services. That's what we're going to talk about, because what we have found out is that we, meaning pulmonary rehab programs in general, have been not doing such a good job saying this is how much it costs us to deliver pulmonary rehab. There's been a lot of surveys done. There's been a lot of information gathered on this. And even CMS came out and told us, you guys, we don't think you're charging enough. It's pretty bad when CMS comes out and tells us that. We know that this code has been underbilled. We know an underbilled code leads to low reimbursement rates. I call it CMS or Medicare voodoo, how they create their charges. There's a way that they create their reimbursement to whatever is charged. It's mathematically done, and there's a whole lot of things that go into it. They do it. That's why I call it CMS voodoo. But what it tells us is that they've come out and told us that we're underbilling pulmonary rehab services, which that's highly unusual. And when there were audits done, we saw that there were all kinds of different amounts. Now, we cannot share what each hospital bills. That's illegal, and you don't really want to do that. But you need to make sure that you're creating your code and your charge based on what you are providing for your patients. So a couple things to consider with these two codes with pulmonary rehab. We are limited to 72 lifetime sessions with Medicare. So know that you only have 72 sessions. A patient, that's all they get. There's nothing extra beyond 72. It doesn't make a difference if they go from a Medicare traditional to a Medicare replacement plan. It's 72 sessions, final, the end. That's all there is to it. It's 36 initial sessions and 36 additional sessions with a KX modifier. Private insurances may vary. I've had patients tell me they can have as many sessions as they want. I've had insurance companies not even bat an eye going past stuff, but a lot of them do limit the sessions. So, but Medicare definitely does, and we can't go through that, and we can't go part of it. Now, one thing to consider, though, is that, healthcare and insurance is a important and valuable resource that we have for our patients, and that just because we have it doesn't mean we have to use it. And this is one of the things I talk to folks about a lot, about just because you have 36 sessions to start with doesn't mean you should use 36 sessions initially. Medical necessity should be your guide. So if your patient's meeting their goal and you can't progress them any farther, it's time to stop charging them and putting them into a maintenance program and letting them go on, and don't use those extra sessions because you can, because are they actually medically necessary for that patient? If they've met goals and they're exercising independently, you don't need to be charging them for their services. So just be really careful with that. If your program is like mine, we have a lot of patients who come back multiple times. And when they do that, you want to make sure you've got some sessions to give them so that they can't exercise with you. Maybe they had an exacerbation. Maybe they had a hospitalization. Maybe they had some surgery and they need your services again, and they need to be supervised for that exercise. You want to make sure that they can get those paid for through their Medicare program. And then, those pulmonary function studies, some of us thrive. I manage a pulmonary function lab, and those pulmonary function therapists are amazing, and they're great, and they love their job. And getting good pulmonary functions is extremely important. But do know that we have to do gold stages 2, 3, and 4 for Medicare to pay for COPD and pulmonary rehab, and make sure that you get really good pulmonary functions. Now, we used to say in the past that a pulmonary function had to be done within a year or 2 years or whatever the period is. Medicare is pretty silent on how current that pulmonary function test should be. So, use your best clinical judgment. If someone's got a really horrible pulmonary function test and they're gold stage 3, that's not going to improve. If it was done 3 years ago, it's probably only gotten worse. And you can use that pulmonary function test. Sometimes medical directors may want something more current. That's something you and your medical director can decide and say, hey, they would rather have a more current pulmonary function test. That's great. Work that out with your medical director. But know that Medicare is really silent on how current that pulmonary function test needs to be. So you just have to have one. And kind of my rule of thumb, there are patients that will often get, and we'll look at their pulmonary function test that may be a year or two old, and they don't quite meet those qualifications. And we may ask to get a more current one done because maybe they have gotten worse in the last year or two. So use your best judgment, use that clinical knowledge, but know that there is no rule about how current that PFT needs to be. So enough about those two codes. Let's talk about the outpatient respiratory services codes. Those are your GO 237, 238, and 239 codes. Do remember, pulmonary rehab, we have to have that pulmonary function test for COPD. The patient has to have COVID for the COVID information. Outpatient respiratory services, we need to have good medical criteria and the clinical need for the services for these 3 codes. Okay, they should be diagnosed with a chronic respiratory disease. They should have increased healthcare utilization. Maybe they're frequent flyers in your ED or frequent flyers at the doctor's office. They should have symptoms, because even despite good medical therapy, they're still short of breath. They still can't walk. They still have weakness, those kind of symptoms. Their ADL and functional limitations are there, and they don't have a good quality of life, and they want to improve that. That's all great medical criteria to put somebody into your outpatient respiratory services program in your pulmonary rehab program. If you've got some COPD patients, for example, every now and then you get a COPD patient that has horrible symptoms and horrible shortness of breath and is not functionally able to do things. But when you look at that PFT, they don't meet those gold stage 2. You can put them into outpatient respiratory services instead, and that's perfectly okay if they meet this good medical criteria that you're looking at for services. So you can still do that. So just watch it, because there are Medicare patients with mild symptomatic COPD that could go in outpatient respiratory services, and that's completely appropriate for your program. The GO, like we talked about, we had the GO codes for a long time. The 424 used to be there. We've changed those to the 94625 and 94626. And then the GO 237, 238, 239s are the valuable other codes. So remember, though, too, those 237, 238, and 239 codes, all of these codes, including the 94625 and the 94626, are outpatient codes. These are not inpatient codes at all. This is all for outpatient services. Don't forget that. That's an important thing to remember. And here are the definitions of the 237, 238, and 239 codes. 237 and 238 are one-on-one codes. So you're doing something with the patient one-on-one because it's clinically indicated to do it one-on-one. 237 is defined as therapeutic procedures to increase strength and endurance of your respiratory muscles. It's face-to-face, one-on-one. It's a 15-minute timed interval, so you're charging per 15 minutes, and it includes any monitoring. You must document the need for one-on-one and the information as to why you're working with that patient one-on-one. So don't forget that. For example, this is a big thing that comes up. Say you have 5 patients scheduled for your class and 1 patient shows up. That does not mean you can charge for one-on-one therapy because 4 patients didn't show up. It was still defined as a group exercise because you had 5 people in there. You can't say, oh, well, 4 didn't show up, so we're going to go one-on-one. You still have to go with the group exercise charge, so don't forget that. 238 is defined as therapeutic procedures to improve respiratory function. Again, it's face-to-face, one-on-one. It's training on specific things that the patient needs to do, breathing retraining, all that kind of stuff to improve their respiratory function. It includes monitoring. And again, you must document the need to do one-on-one training for that patient when you're looking at it. So don't forget that. And then the GO239 is our group code. It's defined as therapeutic procedures to improve respiratory function and increase strength and endurance. Same thing as the 237, only this 239 is in a group, 2 or more individuals. It includes monitoring, and it includes education, exercise, ADL training, all that kind of good stuff. So that is the true definition of these 3 codes. But the key thing to remember, if you're doing the one-on-one, you need to make sure that you're going to document that those one-on-one codes. So what diagnoses are good for these outpatient respiratory services codes? This is just an example of all kinds of different clinical conditions that can meet services. And like I said, you can include COPD in here if they're less than a gold stage 2, or if they don't meet the gold stage 2, 3, or 4 guidelines. But these are all those other codes that you can think about. It is the asthma, it is the CF, it's a bronchiectasis, it's paralyzed diaphragm, it's pulmonary hypertension, it's scleroderma, it's IPF, it's sarcoid, it can be cancer, it can be post-lung transplants that are in here. So lots of things can fall into the respiratory services code. They just have to have a pulmonary diagnosis and meet that clinical need that can justify your services. But like I said, this is just a really good example of all the different diagnoses you can look for, what you can get, and how they can qualify for those respiratory services codes. So when we're talking about clinical indications for your services with these codes, what other things can we actually think about? We talked about kind of those basic symptoms and the diseases. Think about their oxygen needs. Think about their shortness of breath. Think about their inability to perform ADLs, their physical limitations due to their lung disease, requirements for lung transplant or thoracic surgeries. Like I said before, PFTs aren't utilized. Use your evaluation that you're doing with your patient as your case for enrollment. So make sure that you have the documentation to defend your charges in case you're ever asked, why are they in your program using these respiratory services codes? Make sure that you've got a really good evaluation that supports that. And that's extremely important. Okay. Medicare is great. I already talked about that. And a lot of things that we base our stuff on is on Medicare. And we talked about that. But look at our copays for Medicare. And for 2023, if a patient has traditional Medicare, meaning that's all they have is Medicare, they are asked to pay copays for the services. For the 94625 and 94626, that copay is $11.50. For GO239, it's $6.80. For GO237 and 238, it's $5. So if a patient has traditional Medicare, that is what their copay is for their sessions. If they have a Medicare replacement plan, they may actually have a higher copay, sometimes at $30 or $40 per session. Now, I know that we worked with our IU Health Medicare replacement plan and said, hey, this is silly. You're asking them to pay more for the services, and we're losing patients who can't go into these services. And so they actually reduced their copay. So and a lot of Medicare plans actually have done that. But you have to check with each individual plan to say that this is what their copay is, because sometimes patients can't afford that copay. because they've got other things that they want to pay for. And if our copay is too high for pulmonary rehab, they're not going to attend. So, we advocated for our patients that are on our IU Health Medicare replacement plan to make it a more affordable copay for them. Medicare supplement plans often do not have that high copay, so there's a difference between replacement and supplements. So you got to kind of look for that. And then private insurers, like I said, often follow Medicare rules. So you need to ask them about their copays as well. And as you know, every single insurance is different as to what plan they have. And you need to figure out what that is for that patient. And it gets really crazy. Some people may have high copays at the beginning of their plan and lower copays at the end, but you need to do all of those things. Sorry, I blooped backwards for a minute. Now, what about virtual PR and virtual direct supervision? During the public health emergency, we were allowed to do a couple of things. We were allowed to do virtual direct supervision, which is using two-way audiovisual real-time communications. Zoom, it excludes audio only. We could use this in both the hospital outpatient and the physician office setting. And a lot of programs did this and did it really, really well. A lot of programs flipped on the dime, put together virtual pulmonary rehab. They actually called it virtual direct pulmonary rehab. And they've done it well. They did it through Zoom. They flipped and did a wonderful job, and they got paid to do virtual pulmonary rehab. But that benefit is set to end in May of 2023. And that's the benefit that we're really looking to expand on and continue. Now, the other thing to remember with this is it was for pulmonary rehab only. So it was only for our COPD and our COVID patients. This virtual direct supervision did not include the GO 237, 238, and 239 codes. It was only for pulmonary rehab services, so our COPD and our COVID patients. The virtual direct supervision, meaning your physician, being able to contact your physician on Zoom if you need them, that is set to expire in 12/31/2023. And that's another thing that the AERC and the AECVPR are hoping that we can continue that. Virtual direct physician supervision has been excellent for smaller programs and for busy pulmonologists, where if you need them, you can contact them on Zoom technology or whatever technology you can use in your hospital, because it's audio, two-way, face-to-face, and they can help you troubleshoot your patient and be there to virtually supervise your patient. And that has been a godsend for a lot of programs, and we're hoping to keep that as well. Like I said, virtual details are very complicated. I hate the fact that we're ending this PHE in 5 of 2023 with our virtual capabilities of doing that pulmonary rehab. They do not refer to what we do as telehealth. It's virtual direct. It's virtual services. And we're hoping we can get this to continue because it's really, really good. And it affects cardiac rehab as well. So we really want this to continue. The physician offices are a little bit different. They can use it till the end of 12/31/2023 because they fall under a different category if they're doing pulmonary rehab. So if they're doing it in a physician office, they're allowed to continue it until the end of the year, but that is a very limited and very small amount of how pulmonary rehab and cardiac rehab is offered. Most of them are through outpatient services in the hospital. And again, it ends in May of 2023. We're hoping we can push this through, and we're hoping with enough voices we can say, hey, this has been an important service to our patients that cannot get to a physical place to do pulmonary rehab. And there's a lot of really good, successful articles about that. So what about pricing your services? Which is kind of what this is about, but I wanted to give you that background so you can kind of figure out, okay, look at what the great things that we're doing. What about pricing our services? That's important. It's one of the most important things we do. There is the Pulmonary Rehab Toolkit. I'm hoping you will go to either AECVPR or AARC to pull this toolkit up. It was a joint project between our organizations, plus the American College of Chest Physicians and ATS. It's an excellent guide to have. You should have a copy of it, and you should look at it, and you should share it with people, and you'll never hear me say enough about it. This is our second version of it, and I think it's even better than our first version of it. We were hoping after 2010, when we made the first version, we wouldn't have to do this again. But what we have found out is that our PR services, like I told you, are horribly under reimbursed. They're also horribly undercharged. And like I said, it's based on that Medicare magic. We found out on average, a PR session is billed plus or minus $400 a session. And it was done when we looked at 1,350 hospitals' charge data. So we didn't ask each other hospitals. And it varied. It was as low as $100 to as high as $1,000, but the average was about $400. So if you don't know what you're charging for pulmonary rehab, I would ask your billing department to find out what's happening, because it's an important thing to know on your services. And then find out and ask them, how did you come up with that charge? What did they use? Did they ask you, or did they just kind of pull something out of their hat? And that's where this toolkit's going to come in really, really handy. You can see this is our 2023 reimbursement. What is sad, this is pulmonary rehab. Cardiac rehab reimbursement is $120 compared to our $57.48, which was $56.85 in 2022. It's not great. Think about what your cardiac rehab colleagues do, and they get reimbursed at $120 compared to what we do, and we get reimbursed at $57.48. My guess is your cardiac rehab patients do not have oxygen. They do not have oxygen assessments. They do not have MDI instruction and spacer instruction, and maybe mucus clearance device instruction. They may not have high flow oxygen, low flow oxygen, but yet we're getting reimbursed at $57.48. That's kind of sad. And then your GO 237, 238, and 239 codes, your group charge for non-COPD patients or mild COPD patients is $33.96. I don't know about your pulmonary rehab program, but some of my patients who use GO 239 are my interstitial lung disease patients who are very, very sick and use a lot of resources in my program, and we're not getting much payment for them either. So you really need to look and see what our reimbursement actually truly looks at. What's unique is if you look at the 237 and 238 codes, our charge went down on those from 2022 to 2023. There's a lot of history behind that. It kind of got boggled up in some other coding issues. And luckily, our two societies, AARC and AECVPR, worked with CMS and said, hey, you kind of messed this up. And we got it fixed before these reimbursement codes actually came out, because they were kind of really pathetic before we actually got them fixed. But luckily, our societies worked to our advantage and worked for our patients and for us and got those changed, which we are all very appreciative of. So here is your pulmonary rehab toolkit. This is a must in your library. You want this. It's easy to read. You can take it off. It's in a PDF format. You can print it. You can save it on your computer and look at it. It's a wonderful tool to have, and it's going to help you figure out your charges, and it's going to help you take this information to your director and their vice president, and even those folks that charge, and even your people in your C-suite. So it is a wonderful, wonderful toolkit to have. So how do we define our charges? Okay. I always tell folks, I'm a checklist kind of girl. And so in this toolkit, you're going to see a lot of these slides are directly taken from that toolkit because they're really important to look at. When you start, you want to do a couple things. You want to get to your charge master. Those are the people who control what your charge codes are. And for your 94625 and your 94626, you want to say, hey, what are we charging for this service when I see a patient? And you could ask them about your 237, 238, and 239 codes at the same time and look at it. But remember, 94625 and 94626 are bundled codes, which means you are doing a lot of stuff for one charge. Okay, so start with that checklist and say, hey, I want to look at these 5 codes and go on. And then look at what goes into that. Think about what you do for your patients. Think of all the prep time it takes, the face-to-face and documentation time, getting insurance information, writing goals, writing ITPs, reviewing and scoring outcome tools. Think about getting that referral and appointment management in. Someone's got to send you an order. You got to find the patient. You got to schedule that appointment. Think about all the equipment you need for servicing that patient, the exercise dosimetry, the oxygen. Think of all those supplies that you're going to need, the oxygen devices that you have. We have a ton of oxygen devices that we use. Our nasal cannulas, our masks, our oxymizers, our whatever we have. All your sensors that you use for your oximeters, any disposable devices, blood pressure cuffs. Now we're adding face shields and masks into there. Your resistance bands, weights, education materials, handouts. All those things cost money, and we need to think about that. What about recharges you have? Are you blessed with a dietitian that comes to you, but maybe they charge your cost center for it, or maybe it's free? Are you paying your medical director? Do you have psychosocial providers that you're paying for? That comes out of your budget. Think about how much time it takes to conduct a 6-minute walk test. I'm sure you have a 6-minute walk charge somewhere along the line if you do it independent. Look to see what that charge actually is, and think of the fact that we're doing at least 2, maybe 4, maybe 5 6-minute walks in rehab. Think about your assessment time that it takes to do assessments, and then meeting time. So it costs a lot to deliver this service to our patients. It's a good service, but it costs some money to do it. So think about, I said we only get reimbursed at $57.48. That's not what you should charge. And I've heard programs tell me, well, we only get paid $57.48, so that's what I'm going to charge. It doesn't work that way. You're not truly reflecting what it costs to deliver the services. And you want to think about a couple of patients. You want to think about your really high use patient and your low use patient, and then kind of look for that middle ground, that average of what that cost is. Because you don't want to charge high numbers all the time for low level people that aren't going to use as much, but you don't want to charge the lowest common denominator for the people that use a lot. You want to find that middle ground that your average patient is going to cost you to do that. And you want to look at look at that stuff. So like I said, make that list, look for those charges, get your current charge master, and add up all those charges that you're going to do. And you'll be surprised at what it actually costs. And I'm going to give you more food for thought on all those different charges that you can actually think about and consider when you're calculating those charges. This find your person. We've heard find your person a lot. It was kind of a Grey's Anatomy thing, if I remember correct. But there are people that are going to help you. It could be your director. It could be someone in finance. It could be somebody that runs the charge master and patient billing. But find the people that you can use as your reference and say, hey, help me do this. Let's talk about how we're going to do that. And then adjust those charges. They can be your best friends. I love my charge master people. I have a great boss. We have great finance and billing and coding people. So make friends with them, because it's going to help you the best when you're trying to work on this. If you want to increase your charges, find that person, talk to them, bring all those calculations that you've done. Say, hey, this is what it cost me to deliver a session of pulmonary rehab. This is what we're charging. It's not matching up. Be aware, charge masters take place at certain times of the year. We have to have our codes and our charges ready in like Q4 of our fiscal year. So for us, that's October, November, December. So they can be put in January 1. So you want to make sure on January 1, you don't want to say, hey, we want to change our charges, because it's not going to happen until the next year, most likely. So make sure that you find that person that can help you. Because you're going to have to get it approved and talk to your boss, and they need to get everything in. So, look at that and make sure that you're getting that in there. And if you look at the very last box in this statement, it says, keep in mind that CMS has openly recognized that hospital cost reports, the geometric means, are low at $45 per session. That means the reimbursement rate is a direct result of low charge claim submission to CMS, meaning that the root cause of undercharging and valuing our comprehensive services is because we don't charge enough for those. So don't feel guilty. Think about the things we all do for free. I mean, we could put a timestamp on those and say it takes about an average of an hour of one person's time to do all this stuff, or maybe it takes 2 hours of one person's time to do all this. Getting that prescription, looking at those medical records, verifying insurance, explaining pulmonary rehab, psychosocial stuff, developing that treatment plan, ongoing assessment of nicotine dependence, the outcome measurements that we're doing, the exercise prescription that we're working on, the education that we're doing, the conferences we have, the physician supervision, purchasing and upkeep of exercise equipment. There's a lot of stuff we do for our patients, and we need to think about that when we're putting our services together to provide the service and the pulmonary rehab to our patient. Here's some of our unbundled services. And again, this is right out of your book. It gave some base payments that were there for 2022, meaning that that's what CMS paid us back, and the copay that was there. Teaching MDI with spacer, teaching peak flow meters, teaching a check-in dial. Teaching strategies for stair climbing or ramp climbing or self-management plans or smoking cessation and pulse oximetry, breathing retraining, inspiratory muscle retraining, if you teach an IS. Think about how many times you do that in your session and for how many patients you do it for. And even if you do 4 or 5 of these, that right there is $100 or $125 of your unbundled services right there that you can bundle into your pulmonary rehab charge when you're putting that charge together. Here's even more. Smoking cessation, blood glucose monitoring, your 6-minute walks. Think about how often we do those 6-minute walks, and what does your institution charge for that? Any treatments that you would do or wouldn't do. Chest PT or any kind of flutter valve, TheraPap, acapella, mucus clearance devices, pulse oximetry, any kind of educational increments that you can actually charge for. So we're doing all this stuff for a patient, and if we charged independently for each of those services, there's going to be a charge for that. We need to bundle that into one big old charge for our patient. Other things, PT evaluations, OT evaluations, dietary evaluations, E&M codes maybe, when we look at developing ITPs, education and training time. Again, everything that we're doing for that patient, we need to think about individual charges and putting them together in a bundled charge. So write those things down. Make that list. Look at our equipment that we're giving. A nasal cannula or 2, a high flow cannula, a mask, a spacing device. We can't charge for that. Maybe some kind of mucus clearing device or PEP therapy or an IS. We need to consider all those things in our charges as well to remember that. So here's all those crazy equipments. How often you can ask your accounting department to amortize out the cost of a treadmill over years, periods of time. Think of the equipment we have: new steps, treadmills, Airdyne, stationary bikes, recumbent bikes, ellipticals, rowing machines, steppers, arm ergometers, weights, all those kind of things. And the prices of those are going up, guys. I just had to buy a new treadmill, so I know they're a little bit more expensive than they used to be. Our disposable equipment that we have, um, oximeters and the probes and timers and clipboards and oxygen. If you don't have piped in oxygen, you probably have E cylinders and G and H cylinders. How much does that cost your department to have those provided for the patient? I, every time my oxygen bill goes up, I said, well, sorry guys, I can't live without it. And I can't run a pulmonary rehab program without providing my patient the only drug that they need when they're with me, which is oxygen. So I have to have oxygen and oxygen supplies to make this program successful and to make it successful for the patients. So think about those things that you actually are going to use in equipment and supplies. It goes on, and I could go on forever. Think of your rolling walkers. We have rolling walkers, your crash carts, aerobicas, peak flow meters, hand sanitizers, gloves, first aid supplies. What about any software that you pay for? Do you have claims on demand? Or do you have written material that you either do yourself and copy, or do you have claims or some other pulmonary education booklet? And does each patient get that, and what's the cost of giving that to each of your patients when they walk into the door? Books that you buy, department furniture and accessories. Now, that doesn't mean you're going to charge every single patient for a desk. But what that means is that someone can tell you, hey, over time, this is what it costs you to have this equipment. And they can actually amortize it for you and say, this is the cost per patient, kind of that overhead cost that you can actually get a handle on. Your gyms, your staff orientation, your medical directors, the cost of your staff in general, and what that actually is. And so that's important as well. Ooh, I lost my little, there it goes. And then this is an example of your program expenses not related to equipment. You can actually sit down, and you probably do this every year with your budget. This is the cost of your staff. You have 3.5 FTEs for your staff. These are made up numbers, so don't think that this is like a rule and start dividing it out. Maybe you have to pay your medical director. Maybe you do program registry. Maybe you think about, you can get all of this information put together, and this is your total expenses for the year to provide pulmonary rehab for your patients. And it can be higher or lower. This is probably pretty simple stuff, because I know mine's a little bit higher on that. Patient parking. We don't have free parking here, but if I didn't pay for parking for my patients, I wouldn't get parking. So that's an expense I have to think of as well. So you have to think of all of those things when you create that charge for your patient. Okay. What about what you're doing? You're probably thinking to me, Debbie, this seems so expensive. What we are doing is important. Okay. Don't sell your program short. Don't sell yourself short. We're giving patients a great service, and we're improving their quality of life, and we're doing it based on scientific evidence. Think of everything that you do for that patient, because it counts. And don't be afraid to ask for help. Hey guys, I went to school to be a respiratory therapist, and then I did I have 2 degrees in education, and accounting wasn't my thing. Okay, I'll admit that up front. And then when I started this program, they said, hey, you need to create your charge. And I'm like, what? It's not something we learned inherently. Some of you may have an MBA, some of you may have business degrees, and that's great. But I'm not afraid to ask my finance people for help when I say, I don't get it. How do I need to put this together? Use those people, and don't be afraid to ask for that help, because they're going to be so useful for you to creating this charge. And then use the toolkit to educate other people. When you say, hey, I want to look at my charges, and they're going to say, why? Say, hey, look at this data. Look at this information that was put together by these professional societies that said, hey, we're not doing we need to do more due diligence for our pulmonary rehab program and our pulmonary rehab charges. And there's some great information out there. So, there are going to be barriers. I'm going to tell you, and every hospital operates differently. We know that. Even I live in Indiana. Everybody's got a different hospital system, a different way. I have the great honor of having monthly budget meetings with our finance people, and I know how to contact our coding people, and we've got lots of good resources. Other people who have fantastic programs that I know of, they don't have that luxury of having those people right at their fingertips. So be persistent and find that right person to help you, and educate everyone who you report to. You are the expert. Make yourself the expert. Ask for those meetings. Send an email with information. Educate the people around you about how important it is to have good billing for your services, and then use your colleagues. Oh my gosh, I have colleagues in California and in Virginia and in Texas and all over the place that I can say, hey, this is what I'm thinking. What are you thinking? This is what we're doing. What are you doing? Now we can share ideas, but we can't share prices. So do know that that's kind of illegal. So you can't say, how much are you charging for your services? Because I don't think we're charging enough. We can't necessarily share the billing. It gets they kind of frown upon that. But you can share ideas out on how they were able to up their charges or how they were able to reach certain people, and use those colleagues to help you. There's nothing better than that team approach when you're trying to work on this. And lastly, what I want to talk about is our AARC advocacy initiatives. Miriam O'Day is our Senior Vice President of Government Affairs, and we also have CRD Associates as our AARC lobbyists, and they're looking at things for us. I've been on a couple meetings with both of these groups recently over some charge issues and some of our virtual direct information. And so they are advocating for pulmonary rehab for us. They are also working with all of our coalitions, because it's not just us. We're working with the AACVPR, we're working with ATS, we're working with ACCP to make sure that we have adequate reimbursement. So it's an important thing, and that's one of the reasons we're doing this lecture, where they provide comments to CMS regarding rulemaking. And again, we do this as a group with everybody to make sure everybody's represented. We have had private meetings with CMS to address virtual supervision. And I will tell you, when they asked me to help, I went, we're talking to who? And you want me to say what? But you know what? In the back of my mind, I'm thinking, I'm doing this for my patients to make sure that they get the best possible care that they can get, and we're doing all the right things. And then we're working on promotions of this PR Toolkit to help with the C-suite campaign to make sure that this information is getting to those executives in our hospitals. And right now, I got a little email from Miriam the other day, and I'm sure it went out to everybody, that said, hey, we've got some advocacy issues going on. Click that advocacy link on your AARC website, and you can click, and send a letter to your senators and representatives in your state. I did it last night, and it took me less than 2 minutes to get this done. So that information went to them and said, hey, I am a respiratory therapist, and I want to make sure these things are being changed for my patient. And it's a very important thing to do. So I do hope you guys found this helpful. You can always email me through the AARC Connect. That is not a problem if you have questions, and I'll be happy to answer those questions, or you could, and I'd love to chat with you about it. If I don't know the answer, I can sure help you dig it up along the way. So I thank you for listening to this, and we will have a question and answer session, and I look forward to hearing any of your questions, and thank you very much.
All right. Thanks, Debbie. We really appreciate you taking the time to meet with us today. I see a lot of thank yous in the chat box. This is an awesome presentation. I know a lot of people need it. We're going to move on to our Q&A session. I know we're already over time, and if you have to hop off, do not worry. Debbie is staying a little later to just kind of go over some of our questions. Like Miriam said earlier, we had over 1,100 people register for this webinar, which is awesome, but that means there's a lot of questions. So there is no way that we're going to be able to answer all of them, but just to let you all know, we will be sending a email to all of our registrants with the recording from today. We cannot share Debbie's slides. Those are her own personal property, but we will be sharing the recording. And hopefully we're going to put together a Q&A or a FAQ document of all the questions that were submitted. And hopefully Debbie can answer some of those for us and we can send those out. So we'll get started with the Q&A. Let's see what we have first. So this person has a question about billing and codes. Are these relevant to an inpatient skilled facility, or do they differ for specific locations of a pulmonary rehab?
The pulmonary rehab codes are only outpatient codes. If you actually look at their APC, they are truly just outpatient codes. So there is nothing that you can use for the inpatient side at all, unfortunately.
Okay. Our next question is, can we use these codes for diaphragmatic paralysis for pulmonary rehab?
Yes, you can. In fact, the GO 237, 238, and 239 codes are perfect for that. That's what you can use it as long as you've got the clinical evidence that you can do it. You can. We've used it multiple times in my program for those patients. So yeah, you can use it easily.
Okay, our next one comes from Deborah. She says, could you speak to billing and reimbursement for a CORF?
A CORF?
Yes.
I cannot, unfortunately.
We love the honesty.
I don't believe you can, but I'm not the expert on that. So if somebody knows better than me, Miriam might be able to answer that
Okay.
question.
We have a couple CORF questions. So yeah, if anybody knows in the chat, someone that's good with that, just drop it in. So we have a question coming in, says, we are struggling with the right provider ordering pulmonary rehab. Many times it's a nurse practitioner or a physician assistant or a hospitalist that will not work. Any suggestions, or if this is antiquated doctor referral versus PA/NP will change? That's what they said.
First off, PAs and NPs cannot order yet. We are truly working on legislation to get that through so that that will be ordered. It's not only a problem with pulmonary rehab, but it's also a similar problem with cardiac rehab. As far as hospitalists, it depends on, we kind of have set up a unique situation for our order, because we'll often get a referral from our inpatient side, and it may be signed by a hospitalist. But the way we do our orders is that the final order that we get is actually signed by our medical director. But I've got a really good medical director, so it really depends on who your medical director is. But for the PAs and NPs, the only PA and NP that are allowed to sign pulmonary rehab orders is in the VA Medical Center, because the VA self-insures. And they say it's okay that the PAs and NPs sign it. You can take that order, but for anybody else, you cannot.
Okay. We have another one coming in. What about pre-lung transplant and post-lung transplant patients?
Pre-lung, you can use their initial diagnosis. So whether it's COPD, interstitial lung disease, if COPD, you're going to use that 946. The 94626 codes. For interstitial lung disease, you're using the 237, 238, 239 codes. That's great. Post-transplant, you can use the GO 237, 238, and 239 codes. So for post-transplant, that actually falls into there. And again, as long as you can justify clinical need and it's not just a maintenance program, you can easily do that. We do it routinely here because we have a lung transplant program.
Margaret is asking, how do you code bronchiectasis?
It would be the 237, 238, 239 codes, the respiratory services codes.
Okay. Someone else asked the same question. This is not directly related to pulmonary rehab, but related to COVID inpatients receiving respiratory therapy. Has there been any progress on initiating CPT codes for high flow therapy being used for inpatient COVID DX?
That I do not know. That
Okay.
Again, I don't do much good with inpatient anymore. So that would not be my area of expertise.
That is fine. I am also not a respiratory therapist, just work for the AARC. So hang with me, folks. Can you give an example of how you would document necessity for one-on-one?
It would be that your patient is perhaps unsafe. If someone wasn't standing exactly next to their treadmill or doing anything. So it would really be your sickest of the sick patients that you would be documenting one-on-one. So you'd have to document and say, hey, we had to be there. If we weren't there, the patient could fall, he was at risk, or there was a reason that you had to have one therapist with that patient. Now, the reason can't be that only one patient showed up for your session that day. It's still considered a group session. So you really have to make it necessity to the patient that you're doing one-on-one training with that patient, and it's you and that patient interacting.
Okay, we have another question, and we probably have time for just a few more. Can you bill for PFT and pulmonary rehab if they are inpatient rehab hospital? If so, what are those codes?
If you're an inpatient rehab hospital, again, it's outpatient. So those are outpatient codes. Since I manage a PFT, I do know that we do PFTs for our inpatient population. So it's just a regular PFT charge that you're going to have done, because our labs both go into inpatient pulmonary function testing, or have either at bedside or have the patient come down to them.
Sweet. This one's a little off the beaten path, but still a good question. Since most patients who can benefit are not referred by their attending physician, how can we more effectively market our PR programs to our respective medical communities?
Wow, that's the $1 million question. It depends on what you can. Part of being, at least in my job, I always tell people, part of being in my role is not only making sure my program's working well, but getting the word out. You can visit physician offices, you can work inpatient wise and get on order sets, you can use your medical director. We make sure that we talk to our fellows that come through all the time. I'm in a big medical center. It's just really word of mouth. And it is Pulmonary Rehab Week this week, of course. And so, one of the things we always do in Pulmonary Rehab Week is we hit our social media up and have our social media folks come in and do stories on our patients and get that word out that way. So you just have to get creative and talk and get the word out no matter how you can. Get on those committees, get on whatever you can to get the word out about pulmonary rehab. We are not hitting the population that we need to, and we know that it's really difficult. But the more you spread that word and the more you do some marketing, the better off it's going to be.
This question comes in from Tom. Do you have to be certified as a tobacco cessation specialist to charge for tobacco cessation?
I don't believe so. I don't think that is written in the guidelines yet.
Okay.
Because I don't think it is.
Let's look. Is there a specific code for education portion to pulmonary rehab? No. Okay.
It's part of that bundled stuff that you do, unfortunately.
Okay. We had multiple questions about education, so.
Education's good. So that doesn't mean to forget about it, but you just have to kind of build it into that whole charge that you've got. And I did see really quickly, someone asked if you could add the costs of incentive spirometry or spacers and all that kind of stuff separately. And it's considered bundled, so you cannot. So it goes back to how to create that bundled code. If that's something you commonly give out, make sure you include those charges when you create the charge for that bundled code.
Okay, and we'll take one last question. And folks, we will try to get all of these questions answered, if not majority of them answered by Debbie in a FAQ sheet that we'll send out later. But the last one is, can we bill one-on-one charges for initial assessment / orientation when it is not the typical group scheduled session?
If it's a two, that's a really good question. I would say overall, probably not. But what you don't want to do, and here's the question, is that you don't want to not recognize the productivity of your staff. So what you want to do is somehow in your system, however your system works for charging and charting and all that kind of stuff, is we've got some built-in RVUs that are non-billable so that we can still have a productive staff to do that. It stinks that we can't kind of use that. Now, if I go back a step, and I can say this, is that a lot of your codes don't say exactly what exercise you can do. So if you're doing in your assessment, if you're doing your 6-minute walk in that assessment, or you're doing some breathing retraining, or you're doing some education with there, you can probably tweak that into there. But the one-on-one code may be really difficult to use. You might be able to use the group code with that. So it's tricky. Let me hang on to that question, and I'll make sure that I dig into that a little bit more to make sure. But you got to be really careful. So you don't want to get audited. You really don't.
Yeah, it sounds like this was definitely a presentation that a lot of folks needed to hear and were interested in. So again, Debbie, I just thank you so much for taking the time to do this and help some folks out that have some questions about the toolkit. And please, the toolkit is on the AARC website. If you go to our website and go up to the search bar and just type in Pulmonary Rehab Toolkit, it'll pull it right up. It's free. You can download it. So thank you, Debbie. We really appreciate you, and have a great day, everybody.
And everybody, please feel free to get with me through the ARC Connect. I'm happy to answer your questions.
Yep.
Take
Thanks,
care.
Debbie. Bye.